Good afternoon. After much scheduling, rescheduling, overscheduling, underscheduling, and scheduling, we've finally gotten our ducks in a row to do this COVID presentation. My name is Luther Jarmon, Jr. I'm with the New Hope Baptist Church Health Ministry, and the impetus for this presentation is the abundance of misinformation and myths that abound in the public sphere about COVID-19. Misinformation breeds fear. Most of us cling to our fears, which often causes us to give away our power and makes us feel more vulnerable. All of the things we've heard about the risks, challenges, and deaths associated with COVID-19 has definitely weakened our community. While there is seemingly a tendency for some to not take the virus seriously, we must accept the fact that this virus is now a part of our existence, while the numbers seem to be increasing by the minute. This virus is very contagious and its symptoms more serious than many in the past. While dealing with the difficulties of this time, it's important to affirm the positive and remember what is good and powerful in our lives. Parenthetically, knowledge is the difference between those with answers and those with opinions. About this virus, most of us know only what we absorb from the media and the public arena. Today, we have an enormous opportunity to hear from an expert who will dispel the myths and give us trusted information about the virus and the safety and efficacy of the available vaccines. Dr. Marrazzo is Professor of Medicine and Director of the Division of Infectious Diseases at the University of Alabama at Birmingham. Growing up in Pennsylvania, she was inspired to go into medicine by her mother, who was a nurse. She relocated to Birmingham from Seattle, Washington in 2016. In her free time, she enjoys hiking, cooking, and spending time with her Italian Greyhound, Ada. Dr. Marrazzo is internationally recognized for her research and education efforts in the field of sexually transmitted infections, especially as they affect women's health and in the setting of HIV. She is a fellow of the American College of Physicians and of the Infectious Diseases Society of America, or IDSA, and was elected to the IDSA Board of Directors in 2018. She holds a number of leadership positions in the areas of infectious disease research, including serving as a leader of the NIH Infectious Disease Consortium that has studied coronavirus vaccines. At the conclusion of our presentation, Dr. Marrazzo will take a few questions. The next voice you will hear will be that of Dr. Jeannie Marrazzo.
Luther, thank you so much for that nice introduction, and I have to extend a special thanks to you and your team for your patience in rescheduling, unscheduling, overscheduling, disscheduling. I can't even tell you of the confusions and issues, but I'm really, really happy to be here. I'm so delighted to be able to talk about this, this really horrible plague that we've had for the last year, and it's been just a year now that I think was the last time that I traveled by plane outside of the city. So it's an anniversary, I think, that a lot of people are really noting. I'd just like to start by saying that there are a couple of really sneaky things about this virus. And one of the problems and challenges has been that it doesn't do the same thing in every person, and we don't know who's going to experience what type of COVID episode. So, for example, we found out very early that you could have young, healthy people, in particular college students, workers, who would get infected and have very mild disease, or no disease, no evident symptoms, yet they were very able to transmit that virus to their families, and in particular to the most vulnerable members of their families, like older people, grandparents, their family members who might be health compromised, have diabetes, have transplants, have kidney failure, that kind of stuff. So it's been so hard to try to tell so many very healthy young people, whoa, we got to slow down because you're really putting your loved ones at risk. And that still continues to be a theme, right? This whole issue of people not wanting to wear masks, saying it's just a little viral infection. I so wish that were the case, and I hope with the vaccine that will be the case. But we are looking at such an effect on deaths in this country that just last week, the Centers for Disease Control announced that overall life expectancy in the United States dropped by a year because of coronavirus, a whole year. Not only that, what's even worse, if you look at populations of non-white people, look at black men, black women, Latino people, black men lost 3 years of life expectancy in a year of the coronavirus. And black women, almost 2. So what does that say? It says that this is a virus that has taken advantage of all the health disparities that we have experienced for decades, and that people who are most vulnerable are the people who just have not always had the best access to preventive health care, have high rates of diabetes, hypertension, kidney disease, and all that sort of stuff. So it's been a brutal year, and I hope we're getting back on track. The vaccines are a huge ray of hope, and we've seen a big decline in cases in the last couple weeks, last month really, that we think may be partially attributable to getting that vaccine out there. So I'm going to stop there because I'm not sure what else you would like to hear and where you want to go with it, and I want to make sure I get to answer the questions you want to talk about. But that's just, and I mean on a personal level, it's been working in the hospital, seeing teams work, seeing all the nurses, the environmental workers, the people who work in the cafeteria, the people who clean the rooms, the x-ray technicians. Everybody has been a huge healthcare hero. They're just amazing. But it's been hard, really hard to see so many people die.
Well, I have often heard in coronavirus conversations by healthcare professionals the word comorbidity. So please explain what comorbidity means and if or how it increases a person's risk for contracting COVID-19.
Sure. So a comorbidity is a condition of bad health that exists alongside getting COVID-19. So say you are a diabetic, diabetes would be your comorbidity if you got COVID-19 on top of it. Say you have high blood pressure, say you have a kidney transplant, you have cancer, you have really bad obesity. All of those are comorbidities that we learned very early on predisposed people with COVID to do worse than people without COVID. Why is that? We really don't know. It's a really critical question, and we think it may have something to do with the fact that this virus likes to mess with your blood vessels. So we've known that it can cause people to have heart attacks. It can cause people to have blood clots in their legs and in their lungs. And those conditions can be worsened when you have high blood pressure. That affects your blood vessels. Diabetes affects your blood vessels. You can get problems with your vasculature, your circulation in your legs. So we think that might be part of the reason, but we really don't know, and we really need to find out so that we can try to avoid it.
Okay. Now, I've also heard about this virus being able to mutate, which causes great concern. And when my idea of when something mutates means it changes, and what fear I have is that when it changes, does the vaccines become less potent or less effective?
You are in good company worrying about that, because that's what's keeping many people up at night. The virus belongs to a family of viruses called coronaviruses, and they cause a lot of the colds that we have every year, probably about 10 to 15%. And it's a family of viruses that, you never get immune to the common cold, right? I mean, you get the common
Right.
cold every single year, sometimes
Yes, indeed.
multiple times. And so we don't really understand the immune response very well to coronaviruses as a family. This one in particular has been capable of mutating very, very quickly, not just to potentially avoid the vaccine, which we're seeing some hints of. We haven't seen any clear failures of the vaccine to protect. What we're seeing is when you look at these so-called variants, which are the mutated viruses, they have changes in their genes that suggest that they might be able to avoid the vaccines, the antibodies that the vaccines are making our bodies make. We have not demonstrated that conclusively. Right now, there are just hints of that in the sort of the test tube in the laboratory. That said, it's absolutely a worry. And right now, 2 of the companies are with vaccines, Moderna and Pfizer, have already made a vaccine that's effective against the mutated variants. And they're starting
good.
that this week. Yeah. The other thing I'll say is that this virus is so smart, if you like to think of it that way, or evil, whatever you like to think of it as. It not only has mutated to avoid the vaccine, but it's mutated to get better at infecting us. And that's what we saw in Great Britain and England. All of a sudden, there's this mutation that took over. And so that's because the virus got better at basically attaching to our lining of our lungs and our throats and our nose. So it's a scary one, which is one of the reasons that we are trying not to get rid of all the precautions that we've taken at once until we know we've got a good handle on this.
Well, explain what the mechanics of mutation is. What exactly does that mean,
So
mutating?
this virus has a genetic material. So it's an RNA virus. It's like DNA, but basically the genes are a string of compounds in the virus in the center. And what happens, and you can think about them like letters, ACTG, ACTG, that's exactly what it is. And when you say we sequence the virus, we are literally reading the sequence of those letters. They represent the underlying building blocks of the genes. What the virus does is constantly trying to perfect itself to switch out little building blocks in those genes and see what effect it has on the proteins it makes, because the genes tell the cell what proteins to make. And then the proteins come out and make up the virus itself. So virus is amazing. They're always amazing. They're some of the most amazing forms of life, I think, in the world, because they're always switching these things in and out to see, oh, let's look at this. It's like changing your shirt and saying, maybe I'll, do well today because I'm wearing this shirt.
Okay.
And so that's what it's doing. And it's a cost, because not all those mutants or variants are going to be successful. It may cause the virus to die, but what does it care? It's got like 1 billion viruses coming out every second. Well, maybe not that, but a lot. So it's a very dynamic, restless kind of process that just spits out a lot of options, and if there's something that takes, that's what it goes for.
Well, is a virus kind of like, is it like bacteria, something that's alive, or is it just a chemical
It's a great question.
process or
It's a great
something
question.
of that?
It is alive because you can, most viruses, you can actually grow in specialized conditions. So there are some things that can infect us. Like, do you remember mad cow disease?
Yes.
Back in the day? That was caused by a prion, which is, it's a weird particle that is probably not alive. Very strange. But viruses are alive. They can move around, they invade cells, they attach to cells, and you can put them inside cells in a laboratory and actually watch them grow in cells. They can't grow on their own. They have to be inside a cell. Like, that's why they like to infect people and animals, because they get inside your cells and they then can use your body to go ahead and multiply. So they have some things in common with bacteria and fungi, but not a lot. Like, if you look at a moldy piece of bread, that's the fungi that you're seeing on it. That's very different. You're not going to see a virus spreading across a piece of bread because they really need, they need your body, or they need cells in a body that's keeping going. So they are very much alive.
So on an inanimate object such as a table or a chair, they won't be able to live very long.
They won't be able to live very long, although some of them are better than others. Some of the viruses have a protective, almost like a hard coat, I would say. And for example, the virus that causes hepatitis, one of the hepatitis viruses, that can live on things for a really long time. So for example, you can go to a fast food restaurant and get infected with hepatitis because it's been around. So this virus, it's not wimpy. It can hang out on the counters and on hard surfaces, probably for several hours. It's one of the reasons that early in the pandemic, we were so compulsive about washing our hands. Remember, we still are, but I think we've gotten a little bit more relaxed. You remember, some people were putting their groceries on the counter for like hours before they would even unpack them, or they would get their meal and leave it on the counter for a day. I don't think we need to be that paranoid, but I do think washing your hands frequently, and especially remembering not to touch your face, because that's the way you get the virus on your hands, or if somebody's given you the virus by shaking your hand, that's the way you put it in your nose. So,
I went to a nursery to purchase some plants one day, and the clerk, she took my money and sprayed it on both sides. Then the change that she gave back to me, she sprayed that. And the receipt, she sprayed it on both sides.
wow.
So she was very, very cautious.
Very cautious, very cautious. She should be applauded.
Now, I heard you mention the Pfizer vaccine, and I've heard that there is a possible anaphylactic reaction to that vaccine. Can you address that, please?
Sure. So let me just tell you a little bit about these vaccines. Remember that I talked about the genes in the virus, the RNA? The Pfizer and Moderna vaccines are basically blueprints to make a protein that your body then makes antibodies to. And that little blueprint, which is called the messenger RNA, is placed in a fatty envelope, a lipid. It's called a lipid nanoparticle. And that's the reason you can get injected with the vaccine and that blueprint gets delivered to your muscle cells. If you just put that blueprint, that messenger RNA in there, it would disintegrate immediately. It's very fragile. But they use this fatty bubble, if you want to call it that, to protect the messenger RNA and get it into the muscle. That bubble is made up of a bunch of different things. Some of it's fat, some of it is kind of sugary components, carbohydrate stuff. And what we think is that some people have a specific allergic reaction to components of that bubble. The Pfizer and Moderna vaccines only differ in that bubble. They don't differ in that piece of the blueprint. They're exactly the same. So what happened with the Pfizer vaccine when that came out, there were initially, in the first week, about 2 episodes where 2 people who experienced anaphylaxis. And anaphylaxis, if you've had a bee sting or you've gotten penicillin and you're allergic, you get hives, you get rash, you get shortness of breath, you can have trouble breathing, and you can die if you don't have access to an EpiPen, for example. None of the people who had anaphylaxis died, thank goodness. But there turned out to be around 20 cases as this vaccine was increasingly distributed in the United States. It turns out that it is an incredibly rare, probably 1 in every 2 million event, now that we've given so many of the vaccines we know. That said, it's not zero. And so what we have done is to make sure that we ask people if they have had an allergy to any vaccine before. And if that's the case, then we either consider that they get a different vaccine, like the Moderna or the new Johnson & Johnson, which is very exciting, and we'll come back to that, or that they get it in a place where there's medical monitoring, and you can get epinephrine or an EpiPen if you need it. So I think it was really scary that first week, because we were like, oh my gosh, what is this? Is it the virus component? We didn't even know. But I think people are feeling better about it because, number one, it's very, very rare, and number two, we think that if we avoid vaccinating people with a history of allergy to the components of that fatty bubble or to vaccine reactions in the past, then we should be able to avoid it.
Okay, all medicines have to go through clinical trials before they can be approved, generally by an IRB and the FDA and all those processes. And what was concerning to me was this warp speed process. Hopefully it was not skipping steps to really evaluate the safety and efficacy of these vaccines. Now, during these clinical trials, they did not, I don't think they really included as subjects many African Americans, pregnant women, people with some of those comorbidities. So how is that going to factor into getting this country back to health?
That is a fantastic question. So let me just take a couple of points. First of all, the warp speed name was not a great idea, because it really does make people think that we're sacrificing safety and accuracy for speed. And I can tell you, knowing from the inside out how these trials were done, having been on a lot of the calls, knowing the teams involved, I am 100% confident that nobody skipped those steps. It happened fast, but I think they did it well. I mean, I know these research teams, and they really are, the last thing they would ever do is endanger a participant. So I'm pretty confident about it. Obviously, I don't know every single person who ran a study, but I feel pretty good about it. Now, the question of who got enrolled, it's a huge one, because the pressure to enroll was so intense, given the Operation Warp Speed, that they did not initially really build the trust that you need to enroll particularly vulnerable populations. You know that if you want to enroll people who are either sick with other comorbidities or mistrustful of the research enterprise or healthcare in general, you got to take some time. You got to build community advisory boards. You got to have excellent relationship with people in the community who have trusted voices. They did not have any. I'm not excusing it, but they did not, let's just say, take the time to do that. So before you know it, both Pfizer and Moderna had enrolled thousands of people. Right? I mean, they each had over around 60,000, 80,000, 100,000 people in these trials, and only, for example, 9% were Black African American people in both studies about. So that means you've got a group of about like maybe 2,000 people in a study of over 50,000 people who represent Black individuals. When you look at the efficacy of the vaccine in that group, there was no difference, but you could reasonably ask, were there enough people to
Right.
really make us absolutely sure? And I would say maybe, but I would definitely want more. And that's why it's exciting that the Johnson & Johnson vaccine, which just came out, did much better. They actually had about 20% of people who were Black, and did a really good job. We enrolled here in Birmingham, actually, under Dr. Paul Gepfert. So it's not perfect, but better data, more data, and equally reassuring, and equally effective. So I guess what I would say is that there are ongoing vaccine studies for people to participate in. The difference is they will not be tested against a placebo, which is that sugar vaccine that's not effective. All the coming vaccine studies will now be tested against an approved vaccine, like the J&J, Johnson & Johnson, Moderna, or Pfizer. So our plea is that we do need everybody to get into those studies. We really believe they're safe. I've had the vaccine. I think I mentioned my mom today. She's gotten the vaccine. So we do need more people to try to get in and help us make sure that this rolls out. One of the challenges with these studies is that bad side effects from vaccines, like I said, the anaphylaxis is really rare. They're in general incredibly rare. You almost never see them in these clinical trials. So it's not until you get into the implementation phase where you're rolling it out in millions of people that you may see a signal. So we've got to continue to monitor safety in everybody who gets these vaccines.
Okay, if anybody in our viewing audience has a question, just send it in and we'll ask the doctor your question. Now, I have another question here. This is a two-part question. Regarding the health and healthcare, there is a disparity between African Americans and whites, particularly in Jefferson County. Analogously, the rate of vaccines in the African American community is disproportionately less than the rate in white communities. So what needs to be done either by a local government or healthcare providers to effectuate a more precipitous rate in the African American community? That's question one. And question two, is there any way that we as a church can play a proactive role in getting more people vaccinated?
Yeah, thank you for that question. I think my answer is you already are by doing this in a huge way. The first question comes back to that issue of trusted voices. You know, why should you listen to somebody who you think doesn't really know what your life is like, what your problems are like, what your health is like, what your concerns are like with confidentiality, with misinformation, and even a history of concern over being a guinea pig, you know, for some of these things. I mean, there are many examples where people were not treated the way they should have been treated by the research enterprise and by the healthcare system. I think the best thing we can do is have people like yourself, people like your congregants, your members, ask questions and have a conversation. And don't settle for people telling you, this is the data and this is what you need to understand. You need to understand that this is a great vaccine. That's not the kind of conversation we need to have. People need to say, I heard, you know, my mom told me that if I get this vaccine, I could get the virus. I've heard that a lot. Or if I get this vaccine, I'm going to get COVID. Or I'm going to get something else. There's so many concerns with this. I'm going to lose my sense of taste. That's another one I've heard. I won't be able to get pregnant if I'm trying to get pregnant, or if I do get pregnant, the baby's going to be messed up. So we can't just go to places and say, blah, 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 this is what we saw. We have to, like, find out, what are you thinking about it? And I think that's a shift, you know. we're so used to telling people what we think is the right thing for them to do. You know, take your diabetes medicine, take your insulin, do this, do that. And if we don't engage and find out what people are really concerned about, this sounds so easy and obvious, but we don't do it. And so we need, I think, to have more dialogue, more events like this. People can put their questions confidentially, anonymously on Facebook or anywhere. They can call. And you know, we are really, really eager to do it, even though I had to reschedule myself several times. But we are really eager to do it and really want to get out there and help. So I can say that on behalf of my faculty. I have 50 faculty in infectious diseases, and I think almost all of them have been trying to get out there to talk to people. Really proud of them.
You know, years ago, people would not talk about cancer.
Right?
When somebody had cancer, they would say, they would whisper, he's got to pick C. He's got to see us. She's got to see.
Remember that.
People wouldn't talk about it.
Yeah.
But that was a problem, because you have to talk about these things in order to get informed and talk with people who know about these situations, these issues. So just throwing it under the rug doesn't get you anywhere.
It doesn't. And one thing I found is that sometimes people are embarrassed to ask what they're worried about because they're afraid it's going to make them look like they don't know what they're talking about. It's going to make them look maybe not as smart as they feel like they should be. The fear of asking questions is a big one, and especially when you're dealing with a hierarchy, you know, where you're going to ask the doctor the question, or you're going to ask the nurse the question, or you're going to ask, you know, somebody who's an authority the question, and that can be deadly, literally deadly. So there are no, I mean, you hear this all the time, and kids get told this all the time, there are no dumb questions. There are no wrong questions when it comes to this stuff, because, you know, a year and 3 months ago, we had never even, most of us had never heard of this virus.
Right.
So you got to remember, we are all starting from square one here. So please don't be embarrassed, don't be ashamed, don't be scared, or at least do your best not to be, to ask whatever questions you need to feel comfortable that you know what you're hearing, and that you're getting the information you need to make an informed decision. That's really where we want to be.
You know, what you don't know can hurt you.
Big time. Big time.
Okay, I don't see any questions from the viewing audience. Okay. All right, I'm not seeing that. I've heard that there is that someone is, one of the pharmaceutical companies is working on another vaccine. So we have three, right? Mm-hmm. The Moderna, Pfizer, and the J&J. Mm-hmm. Do you know anything about this fourth vaccine that's about to be introduced?
Sure. So there are probably in the pipeline about, let's see, realistically, at least another 10 vaccines. How soon any of them are going to make it to a finish line is a question. Probably the next one that we might hear about is something called Novavax, which is an exciting vaccine because it is a vaccine that actually gives you the protein of the virus, the spike protein, to help you make antibody to that or make your body react against it. When we might hear about that is anyone's guess. I think most of us think it's going to be this spring. So today's early March. I would say we may hear something as soon as April and possibly May. The trials are all running. They're all going well. And I think we should hear, so it's exciting. The one challenge with the trials, of course, is that you can't, a lot of people who were in the trials of the other vaccines have left the trials to get the approved vaccines, right? because why would they stay and take the chance that they got that placebo if they can jump over?
Right.
So that's been a little bit of a challenge, but that's okay. That's the real world, and it's their choice. And if they want to protect themselves, knowing they got a approved vaccine, they can do that. So we should hear, I think, about that vaccine and possibly a few others in the next 6 months, which will be really good.
I have a question here from Loretta W. And the question is, does this virus attack a certain type of blood?
Oh, that's a great question. Thank you, Loretta, for that. So the virus can attack, and I think when you're saying blood type, you mean type AB, type A, that sort of thing that you use to transfuse people or whatever. It'll attack anybody's blood, any blood type, but there is some suggestion that certain blood types are more likely to be affected badly than others. It may have to do with the way that the virus attaches to our cells. So
You mean blood cells?
Yes, not blood cells so much, but the virus doesn't attach to like your red blood cells, as far as we know. What it attaches to are the cells that line the blood vessels, the cells that line your respiratory tract, your lungs, your nose, your throat. So it's not like malaria, for example, which gets into your red blood cells and wipes them out, and you can die from anemia or sickle cell, that sort of thing. But it is related to blood type, and we don't really understand what that's about. I think right now we don't really think there's any reason to tell anybody anything different if they have a different blood type. That's the main message I would give people.
Okay. Tanja Ara says, how long will vaccination be effective?
That is the other billion-dollar question, and that's the other one that keeps us up at night. Why do I say that? For one thing, we've only had these vaccines in the field, right, for about 6 months. So the studies started pretty much late last spring, early summer, I think. So we've only been following people who were in the initial studies for that brief time period. People in those early studies will be followed for 2 years, so we will eventually know how long those antibodies or that immune response lasts. Right now, we can confidently say it's at least 6 months. There are signs that it may be as long as 9 months, and we're really hopeful that it's at least a year. Why am I nervous about this? Because I mentioned before, we get coronaviruses every year, and we don't make long-lasting immunity or antibodies to coronavirus colds, right? We just don't. So is this going to be a situation where the vaccines make your body get very good antibody or reaction, and then over time that just goes down and you're susceptible, or you can get it again in a year? We don't know the answer to that. That would mean, that's what happens with influenza or the flu shot. That's why you've got to get a flu shot every year. So the question is so important because it's going to help us decide whether people need a booster shot every year. And we do not know the answer to that yet.
Okay. Marcia W. said, her question is, when will the next group be able to get vaccinated?
Oh, I hope it's soon. It is. It's been almost like a lottery, right? I will say that the rollout has been spectacular, but also frustrating. I think that in Alabama right now, we have given at least about 13%, 14% of people one shot, and about 7% of people are fully vaccinated. It's a race against time, because if we don't vaccinate more, these variants, the mutations that I told you about or we talked about, could just catch up with us and overtake the fact that we're vaccinating people. So nobody wants to see the immunization slowed down. The challenge has been supply. So we are ready. We've had people ready to vaccinate. I was just at the Hoover Met the other day. It's like a beautiful big stadium area, parking lot. You can go up there. It's just we have not had the supply. Now, the current administration has committed to getting enough vaccine out to get every American vaccinated by the end of the spring. If that can happen, every adult, because right now they're not approved for use in kids. We may see that soon, by the way. If that happens, then I think everybody will be able to get vaccinated. It's just been, we only have so much, we've got to prioritize. So I anticipate that decision will be made over the next month or two as these vaccines roll out. The fact that the J&J vaccine is coming, we got, I think, 40 or 60,000 doses in Alabama last week, but we're not getting any more in the near future because that was it. That was what was available. So it's this kind of like stuttering supply. You get these big shipments, you get rid of that, and then for Moderna and Pfizer, you got to give them another dose. So you got to make sure you save that dose for those people because we're not messing around right now with those doses. At least for the J&J, it's one and done. So long answer to say, I hope it's soon because if we don't get it going into everybody, it's going to be a challenge with those. We worry it's going to be a challenge with those variants and the mutations.
No, I have been on different websites and checked availability of appointments at different drugstores, and it seems that most of the drugstores that are giving the vaccines are in the outlying areas, rural communities. So right here in this community, is there a possibility that we can get vaccinations done here at this church? Is there a process that we can go through?
I don't see why not. I think it would be a matter of working with our team, Sarah Nafziger, the health department. We have managed to work with a lot of community-based folks, so we should definitely look into that. I want to acknowledge what you're saying because I know people, one of my friends who's a 79-year-old woman just drove an hour to get a COVID vaccine, and I forget what town it was, but it's a small town, and she went to a Walmart there, or not to a Walmart, but to a smaller pharmacy. And part of the challenge has been that the state has allocated vaccine to those places. And I think that the intention was to make sure that rural communities were not left out, right? You really want to make sure that no matter how isolated people are from the big cities, they are going to have a supply of vaccine. I think the intention is good. What's ended up happening is that people have traveled, done tourism, vaccine tourism, they're calling it now, right? Some people are even coming in from, I've heard, out of state. I'm not really sure about that. So I think this, I don't envy them having to make those decisions. I think that everybody's trying to do their best. It's just that our best can't be fast enough and good enough right now because we really, really need to get this done. So other people have been talking intensively with the state health department to try to get vaccines here because we have demand here and we could easily literally vaccinate, and we were vaccinating at one point over, I can't even remember how many thousand people a day, but it was a lot. So yes, outreach in places where we want the community to be protected is the way to do it. So absolutely, we should definitely talk about that possibility.
Yeah, so perhaps you can give us a hookup to get it here at this church?
The least I can do. The least I can do. After
all right.
keeping you on your toes.
Karen B. wants to know if people with lupus can take the vaccine.
Yeah, great question. They can, absolutely. The challenge with people with lupus, of course, is not only do they have the disease, but they're often on immune suppressive medications, steroids, other things. So sometimes when people are on those kinds of medications, they may not react as strongly to the vaccine in the way that we want them to. That said, at least from what we are seeing in some of the studies so far, even people on those drugs had a good reaction to the vaccine and made antibodies. So it's really important that you get vaccinated too, because diseases like lupus and the medications to treat them can make you have a bad a worse episode of COVID. So I would say absolutely do it. And no safety concerns that we have seen, no signals yet. So.
Okay, Elaine S. wants to know the safest way of wearing a mask. She says she see a lot of people with a mask under their nose.
Yes, there's some very funny websites that can show you all the different ways of wearing a mask and with their funny little names, like the goatee, people who wear it under their chin. To protect yourself and to protect other people, if you have the virus, you need to wear it over your nose and your mouth. That's the bottom line. Because you can breathe in through your mouth or through your nose, and you can breathe virus in and it will establish infection. And if you have the virus, you can sing or talk or breathe and transmit it. Horrible case of a church outside of Seattle. You may have heard about this very early on in the pandemic last spring. And the people who sang in the choir were trying to be very safe. And they socially distanced. They were 6 feet apart. But they were singing, like, exuberantly, like you want to sing in church, right? And none of them had symptoms, but several of them were infected. And just through singing the way that you sing, in church in particular, they infected almost 30 people in that choir of 60 people, wow. And a number of people died. So just remember, anything that causes you to forcefully expel your breath, exercise, gyms are a big, health clubs are a big issue. We've had a couple of outbreaks here in Birmingham at places where people just feel okay and they're not wearing their masks and they don't want to wear their masks because they're breathing hard. So please wear the mask over your nose and your throat. If you can have it fit as snugly as possible and still be comfortable breathing, that would be really good. It's better to have a mask that's well-fitting and snug than to double mask. I mean, you've heard maybe a little bit about double masking, where you wear the mask you have and then a cloth mask. You can do that, but if you have a mask that fits well and you're comfortable with, you probably are okay with that, especially if you're taking some of the other precautions we mentioned.
I've seen people with just a shield on, and I don't see how that can be very effective.
You're absolutely right. So you mean the lucite shield or the
Yes.
shield, the plastic shield that people use to protect their eyes? Shields are not effective because what happens is you breathe down and everything just pops right back up. It goes out around the area. There again needs to be at least a reasonable seal between your skin and your mask. That's the ideal.
Okay, I have another question here from Annette W. Is the Johnson & Johnson and Moderna more potent than the Pfizer? And the second part of that is, why is Pfizer a two-part vaccine?
Great questions. So both Moderna and Pfizer are two-part vaccines. And both of those, when you looked at the results from those studies, had very similar efficacy. So those vaccines prevented COVID about 94% of the time, extraordinarily effective. They also, if you got COVID, you didn't get as sick. It was really, really very amazing. And there were no deaths in the people who got the vaccine. The only people who died in those big, gigantic studies, like we're talking, 60,000 people, were in the placebo group. So very exciting. The J&J vaccine is single dose, which is, and the other thing about J&J is that it is, it's very forgiving in terms of storage. You can just keep it in a regular refrigerator for 3 months. The Pfizer and mRNA, the Pfizer and Moderna, they're looking at that sort of storage, but in general, you need very deep freeze situation to do it. That's been one of the challenges with getting it out to places that we need to get it out to. So back to J&J. When you looked at the overall prevention of COVID infection in the Johnson & Johnson study, it was 72% in the United States. So people might say, well, wait a minute. Moderna and Pfizer prevented 94%, J&J prevented 72%. Doesn't that mean that the Moderna and Pfizer are better? The reality is that the J&J vaccine prevented 100% of hospitalizations and deaths. It was incredibly effective. There were, again, no hospitalizations, no deaths, and I think almost no severe disease in the people who got the J&J vaccine. So for me, if J&J vaccine was what I had access to, I would absolutely get it. It's a safe vaccine. It's, I think, very effective at preventing what we care about. The people who did get COVID generally got mild to moderate disease. So I think it's as good in most of the important ways, if not all the important ways, as Moderna and Pfizer. But it is confusing, and you will help. I mean, the mayor of Detroit, you may have heard this, he actually refused the J&J vaccine for the city because he felt it wasn't as good as Moderna and Pfizer. That, I think, is not what we want to say. If all you can get is J&J, get it now. Maybe you'll get Moderna and Pfizer later. Who knows? But wouldn't you rather be protected from the really bad outcomes as soon as possible?
Okay, I have an interesting question here from Rita J. She says, I take medication for my heart. My concern is the number of pills I take daily and the reaction that the body may have to the vaccine. How can I put myself at ease about the vaccine?
That's a great question. You know, medications can be tough on your body. Depending on what you're taking, depending on what condition you're taking it for, again, it comes back to that message that we talked about with lupus. It's probably worse for you to get COVID than to get this vaccine. We did not see any interactions between the vaccine and people taking those kinds of medications. Again, I don't know all the ones you're taking, or the diseases that people take those types of medications for. And you mentioned before, Luther, that there were not so many people with comorbidities in those vaccine studies. Actually, it was probably about 20%. So more certainly than Black Americans, for sure. But you know, it was at least 1 in 5, and those people still had excellent outcomes from the vaccine. And very importantly for this question, none of them had more common problems with the vaccine, and they didn't do any worse with the vaccine. You know, they had all the usual stuff that you get, the sore arm, sometimes a headache, nausea. So I would say you're probably good. My advice, if you're gonna get the vaccine, get a good night's sleep the night before. Take all your medications regularly. Make sure you're really well hydrated. Drink a lot of fluid, all that sort of stuff. Get your vaccine. You can take Tylenol if you want to. Some people say you shouldn't take the anti-inflammatory things that we take over the counter, like Motrin, ibuprofen, naproxen, Aleve, that kind of stuff. I think the jury is still out on that. If you get the vaccine and you feel really run down afterwards and Tylenol's not doing it for you, I would say it's fine to go ahead and take something else if you need it. I myself and most people with the Pfizer vaccine had achiness, a little bit of fever. I didn't sleep well that night, a little bit of nausea. And then with the second vaccine, it actually was easier, which is not what other people are reporting. So these are strong vaccines. If anybody's had the shingles vaccine, the Shingrix vaccine, that's what I would expect. And that can knock you on your tail for a day or so. So, you know, what we've been trying to tell people is that if your body reacts and it's, you know, and it's just you feel a little bit run down, that's actually means your immune system is recognizing the vaccine and working really hard.
That's probably why I haven't taken the shingles vaccine. I've got some bad reports about it.
I'm here to tell you it was not fun. I lost a weekend.
Was that right?
Yeah.
Oh, my
it was
goodness.
a tough one, but shingles is not fun.
Thanks for being encouraging.
I'm honest. What could I tell you? I have my credibility.
Okay. I have a question here from Martise W. How cautious should citizens of Alabama be when traveling to states that has removed the mask wearing requirements? Should we quarantine when we return to our home?
Oh, that's a great question. So this is a pretty fresh question because, of course, this just happened this past week, right, with Texas and Mississippi,
Yes.
in particular. And we are kind of waiting to see what happens with those states. Are they going to experience an increase in cases? I would say I would be cautious when I go there. I would continue to wear a mask. And just because there's no mandate doesn't mean that we can't ask people to be personally responsible. And that's how we've been trying to look at this. It's like, okay, you don't have a mask mandate, but every day you wear a mask could save somebody's life. I mean, that's the bottom line. Until we are past this bottleneck of not having enough people vaccinated and knowing what those variants are gonna do, just hang on a little bit longer. So I would go, I mean, it's fine to go, see your family, see whoever, try to exercise caution. You know, coming back, do you need to quarantine? I think it's too early to say that you do. If you go to someplace that's having a massive outbreak, I think that's a different question. But right now, you know, I don't think Texas, Mississippi, and Alabama are really that different. We're all seeing similar rates in the community. So
Right.
I would say if you're cautious, you take care of yourself, you do your best not to get infected, you know, come back and do what you're doing and keep taking care of yourself.
Eric S. asks, how is it determined which location receives a specific brand of magazine, and will we be provided options as to which vaccine we would like to be administered?
Yeah, that's a great question. So when the first vaccines rolled out in Alabama, we just took what we got first. So we got Pfizer first. I got Pfizer. That's the way we did it. Like nobody had any choice. Moderna came in, and people got Moderna if it was available. I don't know how the state is deciding what to send where. I think their feeling is that they are equivalent and you should just use whatever you like. Don't know what the J&J vaccine decision has been and how that's been allocated. I would say it'll be a happy day when we have a choice of which vaccine to get, because that will mean we have enough to have a menu,
Yes.
right? And we just aren't there yet. So hopefully we will be.
Okay, one last question. So does a person that take Mobic or Flexeril, should they stop taking this medication prior to taking the vaccine?
So Flexeril is a muscle relaxant, and the first one, Mobic, I'm not sure what that is. It may be methocarbamol, both probably muscle relaxants. Really, there's no reason that you should stop the medications. Muscle relaxants in particular, the only drugs that, again, I would bring up as that people have talked about are your anti-inflammatories. So Motrin, Aleve, Naproxen, all that sort of stuff, ibuprofen. And let me explain why. Because part of the way that the vaccine works is by making your body create inflammation, right? You're reacting against the proteins that the vaccine is making you make. You're building antibodies to those proteins. You're getting lymph nodes. In fact, some people actually have swollen lymph nodes with the vaccines because the arm is so activated. And that's okay, it goes away really quickly. But you want your body to get revved up in order to protect yourself and make those antibodies. The theoretical fear is that those anti-inflammatory drugs might dampen down or put down that response. I don't think we're seeing that, but to err on the side of caution, I would say I probably wouldn't take one before I got the vaccine. Okay. Tylenol again if you get symptoms, and then if the Tylenol is really not doing it and you're feeling miserable, that's fine, go for it.
Okay, on behalf of the New Hope Baptist Church Health Ministry, I want to say we are enormously grateful to you for taking the time to come and share with us this much needed information. And I also want to thank Dr. Isabel Scarenzi at the UAB Department of Medicine for facilitating this acquisition. Okay, so with that, we should have closing remarks from Pastor Clark.
everybody. Thank you so much, Dr. Marrazzo, for coming and sharing with us. I was here listening to everything that has been said, and I want to thank Brother Jarmon for bringing this to fruition. I heard you say about the J&J vaccine that take it, and even later on, if you want to take a Pfizer one, you could do that. So you can take multiple vaccines?
It's not a recommendation to do that yet.
Okay.
The only time it's a great question, because the only time that the CDC recommends it is, for example, what if you get a dose of Pfizer and then 4 weeks later nobody has the Pfizer vaccine? Can you get Moderna? And the answer is yes. They don't want you to do it, but if that's the only way you can get 2 shots in the time frame that you're supposed to get it, you can do that, and vice versa. J&J is an entirely different animal, so I would say, you know, if you're going to get it, and then probably in a year or so, depending on what the situation looks like, we'll know if you need to get another one. So I wouldn't recommend just sort of double dosing on the vaccines for fun yet.
Okay. Well, thank you so much for coming, and you have been a delight. Our church is a church that we are ministry-based. We don't just do church, we do ministry, and we would love to have an opportunity to help with the facilitation of the vaccines as possible. I have a great relationship with Dr. Wilson at the health department, and if there's any way that we can, we are a community-based church that likes to help out in the community. So for all of you that have watched and participated, thank you so much with your questions. Our moderator, Luther Jarmon, has done a marvelous job, and we also want to thank Brother Denard Jones, who helps to put all of this together for us. Thank you very much. God bless. And now I'll give the benediction. And now may the grace of God, the sweet communion of the Holy Spirit, rest and rule and abide with us now, henceforth, and evermore. Amen. God bless you.
Amen.